All right, guys. So my watch says noon, so we're going to go ahead and get started and welcome everyone to this Friday's webinar. We are talking financial risk versus patient risk. And I think everybody attending this call knows the folks on it. We always have the doctor in waiting, Mia Keeys, who's about to finish her program at GW from the American Medical Association, leading the conversation with my boss and everybody's favorite health equity guy, Dr. Gary Puckrein. We're going to talk financial risk versus patient risk in healthcare. Obviously, this is a topic that Dr. Puckrein has all the data and the numbers about. So get your pen and pad or your laptops and get ready to take notes, and turn it over to the two of them.
Could have said it better, Brandon. I always have at least, reams of paper before I have a conversation with Dr. Puckrein. So I will definitely, if you see me looking down, I'm doing one of two things. One, I'm scribbling profusely, his wisdom, because he's such a sage, or I'm looking at my dog to make sure he's not doing anything he's not supposed to do. That's all that is. But I appreciate the grace, appreciate the space to be here and share time with the NMQF family as usual. Dr. Puckrein, how are you?
I'm doing great. How are you doing?
I'm doing fair to middling. That's what the ancestors say.
Yeah, well, that's a good thing.
Yeah, for sure. But I have to say, and I said this before, and this is really no exaggeration, I so look forward to these Friday conversations for myriad reasons. One, because I know, and I can always trust and believe that everyone who comes here, whether in audience and they're giving us their energy and questions, or the panelists, we're going to talk about something really timely, significant, and all of us are going to walk away, no matter where we start in terms of our expertise, all of us are going to walk away with something new to our knowledge, our bandwidth, right? And then also it just feels good. So glad to be here, sir. I am going to hush now and deliver it to you because you're going to tell us some things, and then we're going to get into a veritable conversation.
Great. Well, thank you so much. So I'm going to start off with a couple of slides to kind of get us going this afternoon. And part of it is really to try to understand when we start talking about financial risk and patient risk, really to orient it in American culture. There are parts of America that we don't talk about, that we hide, and we sort of come to this George Floyd moment when it's our own sort of truth and reconciliation movement. And it's very important for us to understand from whence we came, so that we have some sense of where we're trying to get to. This particular slide, well, let me start by saying, the past administration sent me back to my history books because there was so much going on that it was sort of counterculture to American, what we think of America, that I had to go back and try to understand. And one of the places I spent a lot of time in was looking at the Civil War and the post-Civil War. And the thing that struck me the most about that period, and indeed the whole era of slavery, was that, at least in the African-American experience, our biologies were really supporting an economy. We were literally commodities. And this is a photograph of a family that was taken right after the Civil War. And what you should understand, and we should all appreciate, all the clothes on their back was what their master decided to give to them. That they had no freedom of movement, of their healthcare, their food, their housing, were all under the control of their master. And it was a society of great violence, that the only way you could hold human beings in a state of slavery like this, as the word that was used was make them stand in fear. And that was the whole foundation of that society. And what was important was the decision was made, and Thomas Jefferson and others understood the decision and regretted the decision, but their feeling was that they could not have an economy unless they had slave labor. And it's really important here because some of the decisions that we talk about today in terms of, if you think about the COVID experience, for example, where we're talking about we need to open up the society in order to preserve the economy. That's just another way of saying that our biology needs to support the economy, and that if some of us die in the service of the economy and the status quo, that's okay. That is a really fundamental and deeply important thing to understand, because the nexus between that and what happened in the early years of American history are not very different, when you decide that you want to put your biology in support of the economy. Where I think we're going is we want the economy to support our biology. We want our economy to support our biology. And that's really been the journey of the African American experience. And I'm going to talk about that journey through the lens of healthcare, and give you sort of a feel for how African Americans moved from this picture that you see here almost to a president of the United States, but also within that, the legacy of that system that still remains, the remnants of that system that still remains, that informs healthcare today. So, we talk about health disparities. Well, W.E.B. Du Bois talked about it. Booker T. Washington launched something called National Negro Health Week in 1915. It was a program that the government ran from 1950 to 1951. And a lot of it had to do with those slaves that got emancipated. They had no health care. They literally had to learn how to take on health care in their own family, because a lot of that was controlled by their master. And so a lot of what was happening in that whole National Negro Health Week movement was really working with ex-slaves in the southern states and helping them to manage their health. Healthcare was deeply segregated across the system. And the important thing about that sign, you see it was by order of the police department. That segregation in healthcare was not just in practice, it was in law. And an African American dare not violate that sign. Right after the war, as part of that march on Washington, there was a medical committee for civil rights. So the civil rights movement also had a presence in healthcare. There was a whole effort as part of the civil rights movement, as part of the March on Washington, to bring attention to the poor healthcare, the health outcomes that were happening for African Americans. And part of it was focused on the desegregation of American hospitals, that American hospitals were segregated, and there was a huge fight to try to get them desegregated, because obviously separate was unequal. The hospital systems that African Americans could go to weren't equal. And what you find today, if you go in and you look at the data, we still have minority serving hospitals that where minority populations, African American populations, are more likely to go to than to whites. And in those hospital systems, their resources are limited, and the quality of their care that they're able to get is limited by the investments that we don't make in those hospitals. So even though we've desegregated hospitals, when you actually go in and you look at the data, you're going to find that there are these minority serving hospitals. There are roughly about 700 of them around the country. They're taking care of about 60% of all of the African Americans in the country, and a lot of outcomes that we want to fix can be found in those hospitals. And so what happened was Medicare actually killed Jim Crow, because the way in which what happened was the government paid for hospital care through Medicare, and it forced the desegregation. When hospitals were just being paid with private money, they could be segregated. But once they accepted Medicare dollars, they were desegregated. And the Simpson-Cone legislation, the decision in 1963, brought about the desegregation of hospitals. Medical societies, AMA, I'm sorry, Mia, was also a part of that segregated world.
Don't be sorry, we're going to get into that some more.
Yeah, was part of that segregated world, both at the county level as well as at the national level. In fact, one of the presidents of AMA came to our summit back in about 2009 and apologized. It was the first time that AMA apologized for the segregation that went on in the medical societies and had a deep impact on the ability of minority medical professionals to practice. And you can see, think about it, these are doctors and physicians, physicians and nurses and others who are standing out there protesting and trying to desegregate.
Dr. Ronald Davis.
Yes. One of the things that I always like to call out, the whole federally qualified health clinics that we see were actually started by the Black Panther Party. What they saw was the absence of medical facilities in minority communities, particularly African American communities, and they started building these people's free clinics to provide care for African Americans where there were none in their community, and that later went on to become the federally qualified health systems. But it was really birthed by the Black Panther Party. And so even today, you know, Margaret Heckler's report in 1984, unequal treatment publications, we're still talking about the inequities in the Medicare program and the poor outcomes that African Americans have across all health indicators. All of that really stems back to that whole period of segregation and inequalities. And so I show those slides because too often we forget, we don't understand the journey that African Americans and America itself has been on, and healthcare has been part of that journey. And now we've reached the point in the dialogue where we need to start reimagining our healthcare system. That's really the point, right? That legacy system was built on and produced inequalities. And part of those inequalities, I would argue, stems around the focus on managing financial risk. So we don't talk about segregated hospitals now or medical societies. What we're doing is we're using money and resources to distinguish populations. And the example would be what happened or is happening in Florida with the vaccines, right? We are using money and privilege in order to distribute. And that was most overt, but it happens more subtly across our healthcare system. And so part of, I think, the discussion, not just for African Americans, but I would say for patient advocates more generally, is that we need to focus on patient risk as opposed to financial risk. And what I mean by that is when somebody enters the healthcare system, their expectation is that the system is going to lower their risk. It's going to keep them out of the hospital. It's going to keep them from the emergency room. It's going to keep them from disabilities. It's going to keep them from dying. And that is the whole purpose of the healthcare system, is to manage that risk. And so the challenge that we have is how do we get to that place? Because that's not where we are right now. Where we are right now is managing financial risk. And so that's why I wanted to start this conversation today, because it's a big conversation, because we can't go forward with the legacy system. It is fundamentally flawed. It was built to do something different. It was built to produce inequalities. And you can play at the margins with it, but you're not going to fix it. We have to start anew with a system that recognizes the broad diversity of the American community and is making the commitment to everyone who comes into the healthcare system that the healthcare system is going to operate to manage their risk.
I have a question, Professor. I hope you all feel like I do. Dr. Puckrein is consistently taking us to school, and you know what? In so many ways, Dr. Puckrein, you are not only just a credible and timely thought leader, you really are a master teacher with respect to linking our understanding between history and current day systems. I have to acknowledge a number of things before we go on, because I think it's so salient to the conversation. And I will iterate, in case you have questions or comments. If you have questions, put them in the question and answer box below. If you have comments, keep the chatter going to the side. Questions below, chatter to the side. That way we can very easily distinguish between what we can raise and what you all want to discuss amongst yourselves. So, Dr. Puckrein, you mentioned in so many different milestone policies, right, that were sprung about because of social movements, right? And so when we talk about the current day, as you mentioned, the legacy system, which is not designed to address the needs of a broadly diverse populace, right? We have to talk about the fact that nothing changes unless the public pushes it, right? Nothing, because there's really what's the political incentive for changing the current structure? I'll start there, and then I want to delve into some other questions.
Yeah, so you're absolutely correct. What we've learned is that advocacy is part of healthcare now. If you don't advocate, you don't get. And part of that is there's still the forces of the legacy system in operation. There's still people who believe in inequalities. I think sometimes it's expressed that you can have access to the healthcare that you can afford, that the society essentially has no obligations to take care of each other, that it is sort of dog eat dog out there. And so in order to get to different, you absolutely have to advocate.
Yeah, I've heard you say multiple times that you feel advocacy is just another branch of medicine, particularly in the 21st century. And I don't disagree with you there.
Yeah, I think the minute government came in 1965 with the Medicare and Medicaid program, about half of the US population now are on Medicare and Medicaid. About 160 million Americans get their health care through the Medicare and Medicaid program. And that means that government is probably the largest indemnifier of healthcare in the country. And because of that, they set the tone of healthcare. And we have to advocate in order to make sure that it is supporting our needs, not just African Americans, but I think for every American, and that it doesn't operate just for a privileged few.
Absolutely. You brought up the role of the patient advocate and what, with respect to focusing on patient risk at the, juxtaposition of the healthcare system's focus on financial risk, right? And I know we have a number of patient advocate organizations represented by our audience today. If you were to give them, a summary direct message, what should be their takeaway from what you presented?
I think patient advocates are the catalytic agent for change, right? Unfortunately, the industry components, they're locked into their place, right? They just locked in to where they are. And the way to move them forward is through patient advocates, through the voice of the patient. And that's why they have to be at the table, because at the end of the day, whether you are advocating for patients with diabetes or asthma or sickle cell or lupus or whatever it is, you're advocating for the same thing. You want to reduce their risk. You want them to have the best possible outcome. You want the system to work well for them. And it's that unity of voice around the need to make sure that the system is operating in the best way for patients, I think is the change. And I think members of Congress absolutely have to hear that because they're locked into financial risk. They're managing the Medicare and Medicaid program from a financial perspective, right? And they need to understand that really where the future is to manage it to reduce patient risk. Because here's the point. We are getting so smart that a lot of these diseases we can learn to manage and control. Look what we did
with COVID vaccine.
With COVID.
Right.
I mean, come on.
Mm-hmm.
The example is right there.
We
right?
do the vaccine itself was technically developed in 4 days. I mean, in terms of, you know.
Yes, come on. Absolutely. And we can put our foot on the gas because what we don't want to do is have this wonderful capacity and then kick the can down the road for the next generation to have to fight with this. We don't want our kids to have to live with diabetes or lupus or asthma or whatever the heck is confronting them. But the only way there is through managing patient risk. So.
It's through managing patient risk. And I would also add to that, it's to getting ahead of the curve. You know, I'm having the damnedest time trying to come up with a moment in history where our milestone policy was not preceded by some sort of public health crises.
Yeah, unfortunately, it takes the big stick to get us, on the right road, right? I mean, look at where we are right now. So we've got COVID going on. Texas had its shutdown with electricity. Mississippi's got its water thing going on. California's got its fire thing going on. And what it all says is we have to build our economy to manage our biology, to avert risk and to avert these critical events, because sooner or later, we're not going to be able to afford them. And probably even more important, civilizations are not guaranteed. They can collapse, right? They absolutely can collapse. And so we need to build in those redundancies. And I think the way forward on that is to focus our attention on how is our economic system supporting us, as opposed to saying that our biologies need to support the economy.
So I want to tease out the biology and economy significance. And forgive me, if there's a lot of noise in the background. You know, these helicopters these days in DC, all over the place. Shout out to Delegate Norton, Representative Norton, trying to get some things through the Quiet Skies Caucus. So let's talk about economy and biology. You know, so foremost, and I'm going to call out the AMA, but I'm also going to, with respect to what you pointed out, but I also want to acknowledge that the AMA is coming along, and we keep in some ways we get some things right, and in other ways we still have a long way to go, right? So you mentioned that the AMA was really very instrumental, like directly instrumental, with barring membership of Black and Brown physicians through its 174-year existence up until the 1960s, 1970s, we started to see some things. But it wasn't until, as you mentioned, 2009, when Dr. Ronald Davis, who was the then president of AMA, issued a public apology to the National Medical Association at their annual meeting, specifically for the AMA's role in keeping Black and Brown physicians out of its membership, which a lot of people might think it's really just a symbolic thing for Black and Brown folk to be physician members of the largest, most powerful, most heavily pocket lobbying and voice of the physicians of the nation. And it's not. It's because, you know, if you're not a part of the membership, particularly on the state level, that impacts your ability to acquire and to sustain licensure. And if you can't have, you know, your proper license, then you cannot practice. And when we're talking about the patient body of people, you know, Black and Brown physicians have historically been providing care to, it's Black and Brown patients, right? So that of course leads us to where we are current day, which is, dearth of workforce, representative workforce, people still having issues with respect to access, and of course, issues with respect to cost, right? So that's one point. The other point is, even just yesterday, well, rather, let me back up and then I'll mention this, and then I want to deliver it over to you. In November, the AMA passed a historic suite, a tri-suite, if you will, of race-related policies, anti-racism related policies through its House of Delegates. And by the way, the House of Delegates meets twice a year with the AMA during the annual meeting in June, the interim meeting in November. And through the work of the Minority Affairs section, which has quite a relationship with NMQF, through the young physicians, through the medical student section, host of allies across the board of trustees and throughout the AMA, they passed these policies, one of which says that, racism is a public health threat, right? And another one having to do with racism or race not being biological, but racism being a social construct in nature and having everything to do with, the foundational cause of health, which has to do with socioeconomics, which is essentially what you're pointing out. And then there was another one passed around racial essentialism and ridding the use of race as a proxy variable within research and clinical trials. But the point that I wanted to bring up today is, it's very hard for a number of people, to your point, to wrap their eyes, their whole being around the idea that racism exists, because they're thinking about it in an interpersonal way. They're thinking about what I do to you, what my ancestors have done to you. They're not thinking about it in terms of structural racism. And this even came up in a podcast that the Journal of the American Medical Association put out a couple days ago, which, by the way, is separate from the AMA. So if you've come across that, please know JAMA, the journal, is different and is not a part of AMA, although our CEO was very clear to say that we abhorred everything that came out of that podcast, which essentially people in the podcast were saying that structural racism doesn't exist. So I say all that to say, we still have people, to your point, that feel and believe in inequities, that inequity is the crux of what makes capitalism work, what drives our economy forward. What kind of argument do you use? Do you use the economic argument to then purport that structural racism remains, it lives, it breathes, and it mains, and it hurts and disables? Where do you get in terms of arguing against those, that rhetoric?
Part of one of the things I always remind myself of, ideas are almost impossible to kill. If you doubt me, Google flat Earth. There's a flat Earth society out there. There are people who still believe that the Earth is flat, and they meet and they speak with each other. Or QAnon. So you quickly see that ideas can have a life of their own, and hard to ever get rid of. That's why the attention has to be on metrics, on measurements. Queen Elizabeth I of England, when she was reigning, it was the fight was between Protestants and Catholics in England, and she said, "I don't want mirrors into men's souls," and I would say the same thing. We actually don't want to get a mirror into some person's soul. What we want to know is that when I or anyone enters a medical facility for care, that everyone in the establishment is working to reduce the risk. And we can see in the aggregate from the data how successful they are at doing that. And we should have no systems in our society where people are walking into a facility and their outcomes are manifestly poor all the time. And that's what disparities really are. And I think if we can get our minds focused on measurements and measuring, and quite frankly, right now we don't have good measurements about our healthcare system. Medicare is operating with, it's got some measurements, but no one actually takes them seriously. And that's the point, right? People can live with their biases, but they got to leave those at the door if they want to be in the healthcare system. And if everyone is focused around that, I think that's the beginning of the change. Would be my sense. Now, I also want to make this point because I think it's important. I like the idea of the private sector. I like the idea of the innovative capacity of the private sector. It has to be held to account like anyone else, that it's not doing god awful bad things. But I think one of the real beauties of American culture is its ability to innovate, and what we want it to do is to innovate in the interest of every American.
I really appreciate that, because we do also now see this uptick in private corporations having conversations around diversity, equity, and inclusion, right? And I can't speak for everyone in terms of their leadership commitment and, thorough vetting of their entire corporate structure down, from its board and CEOs down to but inclusive of its managerial staff and everyone who keeps the ship rowing, right? So what then do we speak of? What do we expect? How can we reimagine or hope to reimagine, the risk abatement, mitigation with organizations that, don't have to answer to the public?
Sure. So one of the important things here, and this goes back to the idea of our economy in support of our biology. The historic model, at least, that a lot of our legacy systems were predicated on, they were predicated on our biologies supporting the economy. Could be child labor, it could be African American, it didn't matter, right? I mean, it was our economy being supported by our biology. When you flip that and you turn it around and say, let's have our economy support our biology, what that means is we each become invested in each other's health, right? That wealth is found in keeping each other healthy. And I think that is so transformative, right? Because all of a sudden, your neighbor's health becomes part of your business enterprise. And I think that's transformative. I don't think it's easy to get to, mind you, because I think, the culture, deeply rooted culture that we have is people who still fundamentally believe that the only way business can move forward is to have people to throw their biologies at. But I think we can do something very, very different. Certainly, when I look at what goes on in the pharmaceutical industry, for example, fundamentally that's their business model. Sometimes it gets corrupted by some god-awful people, but basically their business model is to find new ways to keep people healthy, and to take that knowledge and disperse it, and they get rewarded for it. I think hospitals sort of in the same business. They get hamstrung by the way in which we fund them or not fund them correctly. But I think if we, and I think I'd push the envelope even harder. What I would say is, I think in the 21st century, if we're going to get through this period with everything that's coming at us, understanding that the economy has to support our biology will become more critically important.
I cannot argue that at all. I'm thinking about it. My mind is racing in a number of ways, and I want to make sure that my questions are really going to draw out your wealth of knowledge so well. But let me raise a question from the audience. So there's an audience member who wants to know specifically your thoughts on lack of diversity with respect to, and I assume this person means racial diversity as it relates to health outcomes of patients. And they're saying, you know, we need Black and brown providers at the table to elevate the voices, the health needs, the health concerns of those who are historically vulnerable. And so what are your thoughts? I've heard your thoughts a trillion times. You can say a bit more and we'll connect it to the larger conversation.
Yeah, sure. One of the good fortunes I have in living in Washington is that Washington is forever having meetings and conferences, and there are all of these think tanks, and they have these meetings, and they often talk about diversity and inequalities and the need to eradicate. But they're very, really diverse. The voices at the table are very, very, really diverse. And what's important about that is that I think diverse voices bring different perspectives that come from a deep set of history that many people have not experienced. You know, the African American experience, at least in this country, is unique. You know, I think you saw by that photograph that I showed you that, you know, African Americans could not be part of the quote capitalist society really until 1965. Many places they couldn't even own property, let alone run businesses. And even today, we still live with the problems of absence of capital and the challenge of getting diverse workforces, et cetera. So part of that, and it makes it difficult because those voices have not always been allowed at the table, but now they have to be if we're going to really reimagine a society that works for everyone. It's hard to reimagine that society if you're limiting the voices and the people who are participating at the table. So I think it starts there, and it has to work its way through. You know, we have to get more minorities in the medical professions. If you look at African American males, they're becoming an almost extinct population when it comes to physicians in the country. COVID has really turned upside down education, and is going to create, it has created enormous damages. So I guess the point I'm making to you is, I think it begins by making sure that who's at the table, and to make sure that we have all of those diverse voices. It makes it harder because they bring different perspectives, and they'll push in places that folks may not want to go, but that's the whole point, right? If we're going to reimagine, it's going to take that consensus building to get there.
Let's start there. I love that. If you're going to reimagine, it's going to take the consensus building. So let's just go through an exercise, and those who are at home or in your offices, you can do it yourself. If we were to say to ourselves, based on your premise, which is the economy should support our biology, if we were to imagine what that looks like, or reimagine what that looks like across all sectors, and let's call each sector out, let's play with an idea of what that might look like. If we can start with, you just started already with respect to medical representation. I could say, imagine if our medical curricula reflected the history that you just so eloquently and vividly laid out. Yeah,
well, so the historian me always says that you have to understand your past, and I know medical school is crowded with information that they're trying to force and get people to consume, but a little bit of history setting and culture setting, I think, is an important thing, both so they understand the patient community that they're interacting with, and understand through their lens the world that they see and why they have this distrust and uneasiness. When you come to them and say, I want to give you a vaccine, it's going to help you, and they look at you and say, oh, probably not, because there's a long tradition of that. And so I think, as a matter of cultural competency, I think that's incredibly important. But what I also think is important is that we have to turn our healthcare system into a learning system. So let me give you an example of exactly what I'm talking about from a clinical perspective. Right? So when we look at the data, I'm just going to hone in on diabetes for a moment. We can pick another disease. The number of people who get hospitalized in the Medicare program with diabetes doesn't change very much from one year to another. It's almost a flat line. For 5 years, you got a flat line. The same thing with ER visits, right? It's a virtual flat line from one year to the next. I translate that to mean that the system is not learning, right? Because if the system is learning, what you should see is a downward trend. And that's the point, right? If we're really focused on patient risk, we are constantly monitoring and looking for how do we take those trends and get them turned downward, right? And that's where our future lies, is getting the whole system to follow the science, to operate with the science to reduce patient risk. What's happening right now is financial risk is intervening, right? And everyone gets so concerned about financial risk, and they're measuring that constantly. How many dollars are we spending on this or that they lose sight of the patient. And what's actually happening is the system is not learning from the perspective of managing patient risk. And we can go across that. And so what I would say to patient advocates all over the place is you should be measuring improvement in the delivery of care, so that you get downward trends in what I would call acute events, hospitalizations, ER visits, emergency room, mortality, disability. All of those trend lines we should be pushing down.
You know, that to me is the epitome of activating an equity lens within healthcare. You know, and I think what you're helping our audience to do is really simplify their vocabulary with respect to addressing inequities in healthcare. Because right now it's so sexy, it's so seductive to use the terms disparities, social determinants of health, equity, structural racism, where more than likely people don't know what you're talking about. It's like saying, you know, everyone go sit in the chair, and you assume that everyone's chair looks like your swivel leather chair. Mine looks like a rocking chair. Somebody else's looks like a bar stool. You know, we're not talking always about the same thing, but we let that slide. But what you're saying is everybody gets risk. Everybody understands risk. We feel it in our pockets. We feel it in our bones. We feel it, you know, pretty much throughout all course of life, right? You're saying patient risk cannot exist, or excuse me, patient risk has a very low chance of existing if you're focusing on these metrics: quality, safety, and basically that's all equity.
Yeah, you're absolutely right. So it's interesting. There was a physicist, John Butterfield, who worked on the Higgs boson, and he wrote a book. And in the book, he recounted a discussion that his son had. His son, 7 years old now, was at school, and the teacher asked, why do people take risks? And the answer was, they always take risks. They only get to choose what risks they want to have. But life is taking risk. And that is exactly the point. You can simplify the equation down to managing patient risk, because in effect, when you're talking about equity and you transform it into patient risk, you're taking it beyond just equity in the sense of in the moment. You're saying that going forward, what I always want to keep my eye on is, am I getting smarter? Is the system operating in the best interest of each patient? And we can measure that. We can turn that into a math problem. And so at that moment, I actually don't care what anybody thinks, right? What I really care about is, are we keeping people with heart failure out of the hospital? Are we helping them to stay out of the emergency room? Are we extending their life? Same equation for cancer, same equation for lupus. It's all about risk management. And so I think the power for those in the equity movement, in the quality movement, in the patient advocacy movement, is that harmony of that commitment to managing patient risk.
You know, in that way, then equity becomes less of a political moral issue, which is where people get tripped up.
Exactly.
And it becomes a conversation that for quite some time doesn't necessarily have to be political in nature.
Yeah, because the answer is, we're really talking about the human condition, that we're all facing the same human condition. And what's intriguing is the 1%, we can't even build a healthcare system for the 1%. They think because they got that vaccine in January that somehow they got to ride in the front seat of the airplane. No, maybe you got that vaccine, but how about that cancer? How about that heart failure? How about that kidney disease? All of those things you can't buy for the 1% because the system doesn't work that way. We are all in the same boat, and the way we learn and the way we execute in a very smart way is to manage everybody's risk. And if we're doing that together, I think we get a very smart healthcare system that is moving quickly to address and control health outcomes.
You know, there are others who would argue that basically what you're talking about in a lot of ways is like a socialist medicine type of model.
That's always, I always find that interesting because healthcare is about a collaboration. Ain't nobody I'm aware of is going to have a healthcare system that is singular to themselves, right? It is, in fact, our ability to manage disease is a deeply collaborative enterprise. Think about the development of the vaccine. Yeah, you develop the vaccine, but if you can't distribute it, it doesn't make any difference at all, right? And so, and that's the whole point. People get caught up in a world or a set of language that belongs to a prior generation that's not applicable here. What we're really talking about is that we all have to work together to get the best possible outcome for each and all of us. And that's just the fact. You cannot build a real healthcare system that is managing all of the diseases. There's 72,000 of them that are in the ICD classification of diseases, right? 72,000 of them. So how are you going to build a healthcare system for one person? It's not going to work. It's all about a collaboration.
So Dr. Puckrein, you started this conversation with giving us a very, vivid, albeit brief outline of the 18th and 19th centuries with respect to where we were as a nation in terms of valuing Black bodies, especially brown bodies, right? And so we don't even have, there is a part of us that has to imagine, that has to rely on these media projections about what the past has been. So we go to movies, we watch documentaries, we read books, right? We gather from those who have done the work. And sometimes there's a political bend to it. Sometimes it's just, people are presenting the facts as they were. But we don't have that ability, obviously, to thwart us in the future, to be able to see. You're right. And that's what you're asking us to do right now, to be able to see, to suspend where we are, our current day, to imagine, right? So what do you imagine if we don't get a hold of this now, where the economy supports the biology? What is the new biology that will be harmed? Will it, is it bodies as we know it? What's the new frontier in terms of where we need to be imagining moving forward? And not to discredit what you've already said, because you've already said we haven't,
I think really we are on the cusp of doing things that were earlier generations would find unimaginable. We are right now at the genomic level, which means that we can reprogram our biology. 18th and 19th century didn't even understand atoms, let alone understand about genes and how to manipulate them. When you look at some of the new devices that are coming on stream that are going to find cancers at stage 1 and 2, well before patients are symptomatic. When you look at the interventions with some of the chronic diseases, look at what we did with HIV. We turned that into a chronic disease, and no doubt we'll find a cure for it before it's all said and done. The question is, can we liberate all of that capacity? Can we put together a financing and delivery system that liberates that, not only liberates it, but accelerates it, that warp speeds it? Because when we come out of the 21st century, none of these diseases should be a trouble to us. That's our future. That's what we can own. That's where we want to go. But in order to get there, you're absolutely right. We have to liberate ourselves from our past, which is incredibly difficult, right? I suspect that it's going to take some leadership, some folks who are visionaries who will put together the systems to make that happen. If you look right now, people talk about telehealth, and they seem to be talking about getting in front of your computer screen and having your doctor talk to you. No, that's not where we're going. Where we're going in all kinds of devices that are going to measure our biometrics constantly for the purpose of intervention. Look at, if you doubt me, look at what's going on with people who are raising cattle these days. They are putting devices on them that manage the health of the herd, and so they can keep their livestock healthy, computer-based, right? That's what I'm talking about. I'm really talking about what the 21st century has to hold for us, and we just got to get ourselves free from those who want to live in the past, from those who like that segregated inequality, feeling your privilege, because any good scientist would tell you there is no special reference point for anyone, that we're all subject to the same laws of nature that we have to learn, and in learning them, apply them to everyone, because that's our future. And certainly, I would say from the African-American experience, from the journey that we've been on, that's our journey, is to help. When I was spent some time, obviously, teaching history. And what I recognized about the African American experience was that we were the canaries in the coal mine as it came to democracy, when it came to living up to the principles of the founding fathers, that their vision, which they did not achieve, that African Americans could pick up that voice. And that's what Martin Luther King, Frederick Douglass, W.E. Du Bois, all of them were speaking to. And it's that same movement in healthcare right now, but we're not talking about desegregating hospitals or medical societies. What we're talking about is liberating our ability to intervene and have a healthcare system that is focused on and managing patient risk for the good of everyone in this society. And that's why at NMQF we don't talk about disparities anymore, because when we were talking about disparities, we were talking about using whites as the reference population. That's not what we're talking about now. What we're talking about is something I think much more profound that we have the capacity to do.
Of course, in my mind, I hear Bob Marley, emancipate yourself from mental slavery. None but ourselves can free our minds. That's what you're talking about here.
And looks like.
That is what freedom looks like. But what he was singing about was, it was a song about the imagination. It was a song about the collective consciousness and the raising that we were obligated to share these visions, right? And it doesn't necessarily mean, the beautiful thing about people like Du Bois and King, who we call upon at least 28 days out of the year, right? For the great American public during February, right? It doesn't stop there, but I'm not sure that everyone sees themselves in the same light as a King. I'm not sure that everyone sees themselves as, believing in their ability to imagine, especially if they're just so tired, or if they're focused on survival, or if they just feel that it's someone else's job. In these last 2 minutes, Dr. Puckrein, what is our missive?
Yeah, I think you're right. I mean, this is not a journey in terms of thinking through and helping to reimagine the healthcare system. I think it's a process that has to go on. That's going to take some time to do, but it's going to take some leadership, some committed souls. And that's why, again, I think patient advocates have such an important role to play here. That a difficult role, to be sure, because it's not comfortable to step out of the box and sound that discordant note, because you're taking people out of their comfort zone, and they don't want to leave that easily. But if you look at what we have the opportunity to do and what we have the opportunity to become, you're comforted by that, and you know that the way forward is really to help our healthcare system take as its prime directive the management of patient risk. That if it focuses there, if it focuses energy on there and pushes back on those that slow us up from that journey, I think we'll be okay. I really do. I think that is our future. I don't see another way forward. I think I think the objective reality is going to punish us if we don't do that. We're going to have more COVIDs, more blackouts in Texas, more firestorms in California, water shortages in Mississippi. I mean, the objective reality is pretty clear about what it's requiring us of, at this moment in time. And I think we will one way or another react to it.
That we will. Dr. Puckrein, this has been a pleasure. Always, I wish we had more time, but I imagine we will in the future. At least I certainly hold on.
I always enjoy having these conversations with you. They're really a pleasure.
Absolutely, sir. I thank you for your time. And I just want to say thank you to the NMQF team who is consistently putting these conversations together. We appreciate also the audience who consistently comes. And so in lieu of Brandon giving our salutation, I just say thank you. I hope you all remain safe and well and hydrated, and peace to you and your family. Looking forward to the next conversation. Keep the questions coming.
Bye-bye.